Good evening or good morning, wherever you are in the world, and welcome to this Ifso webinar addressing the important issue of registries. My name is Wendy Brown and I'm the current chairman of the Ifso Global Registry Committee. I'm based in Australia in Melbourne, and it's about 10 p.m. at night here, so that's why I'm saying good evening from Melbourne. But I know in other places in the world, such as where Ronald Liam, one of our presenters from the Netherlands, who's the deputy chair of our committee, it's the middle of the day. But just to join me in the late night sort of hour is also Jennifer Holland, who is the lead of the Australian New Zealand Bariatric Surgery Registry. She is the Chief Operating Officer, and she's also been involved with helping to collate the Ifso Global Report. So I'm very glad that all three of us are here tonight to talk to you a little bit about registries, why bariatric societies should think about having a registry, what registries look like, and then also as we start to look towards our next global report, how we're going to put that report together, and finally activities that the committee has got planned for the year that will help to support national registries moving forward, either existing or registries that are sort of wishing to exist. This is a webinar, and we're very grateful that many of you have joined. There'll be time for questions at the end, and if you could put those into the chat, that would be great. Manuela, as always, is providing amazing support, and she will help us with those questions. And just as a reminder, if you're not able to watch the whole entirety of this webinar, it will be available from later on today or this evening through the Ifso Virtual Academy channel, but also through the YouTube channel. So without any further ado, we'll start with our first talk, which is I'll be presenting a little bit about registries and why they exist. That'll be followed by a talk from Jennifer Holland around the Ifso Global Registry and how we'll be putting the next report together, and things that perhaps you need to do if you're considering contributing to that report. And finally, the last talk will be from Ronald Liam, and that will be around the activities of the Ifso Global Registry Committee and some of our future aspirations. And then at the end of those talks, Ronald will lead our discussion time. So thank you once again for joining us this evening. So Manuela's going to start.
Good evening, my name's Wendy Brown. I'm the current president of Ifso Global Registry Committee, and I thank you for joining this webinar tonight. Disclosures, and just to note that whilst this is an Ifso endorsed event, most of the opinions that are expressed in this talk are from my own research or my own opinions. And these are my funding disclosures. We're here tonight to talk about registries, and I think it's really important at the outset that we have a sense that we all agree on what a registry is. The Agency for Healthcare Research and Quality defines a registry as an organised system that uses observational study methods to collect uniform data, which could be clinical or other data, to evaluate specified outcomes for a population defined by a particular disease, condition or exposure, and that serves to determine a predetermined scientific, clinical or policy purpose. So the key words in that definition is that it's organised, that you use observational study methods, and that the data that's collected is uniform and has been previously agreed upon before you start the exercise. There are different types of registries, and these registries can be based around a condition or a disease where you're just collecting information about those conditions or diseases. They can also relate to collecting data on a particular device, drug or product. And finally, we have clinical quality registries, which focus on the quality of care that's being delivered. So clinical quality registries are what most of us in healthcare tend to be thinking about, and these clinical quality registries routinely collect and analyse and report on information that's been prospectively identified as a good marker of care. So if you look at the care pathway from diagnosis, investigation and management, at each of those points, a team of people, typically a multidisciplinary team of people, will typically decide what things at each step are indicators that good quality care has been delivered. You then have to define what those items are, and then you need to measure them systematically across multiple sites. By doing this, you can identify if there's any significant variance, and you can also benchmark performance. And that information can be used to inform improvements in healthcare quality. So When we talk about clinical quality registries, we're again talking about purposeful collection of a limited data set with predefined common data dictionary so that we know we're collecting the same thing across every site where the registry is being undertaken. A registry is very different to a clinical trial. Therefore, so in a registry, we're trying to get the whole population. It's observational. We're looking backwards at what's happened in the past or we're measuring as we go forward. But we're not changing the intervention. We're just looking at the intervention. Whereas in a clinical trial, we're typically trying to compare two different types of treatment options, and the trial itself dictates the management plan. And again, in a clinical trial, because we are just comparing two different potential treatment options, you only need a sample of a population or a small sample size to give you some very detailed information, which helps you to detect any positive or negative outcome. So when we think about the different types of studies that we have available to us, when we're thinking about evaluating a new idea or a new technique, at the idea stage, we're usually thinking about case reports. So that someone's come up with a new operation, for example, that sounds like a good idea, and they write up that one case report. It then gets further developed and evaluated through a case series where a number of the same operations are reported upon, then gets explored a bit further when it becomes a sort of agreed technique by having some prospective cohort studies where you measure the outcomes over a longer period of time. And then you might compare your new technique to the old technique through a randomized controlled trial. And finally, to monitor the long-term impacts of this new surgical technique, you need registries to enable you to collect that data into the long term. But again, you need to agree on why you're doing the registry from the beginning, and you need to know what you're measuring and how you're measuring it. Because the foundation of any clinical quality registry is reliable data. If you don't have reliable data, you don't have a registry, and you don't have anything that's useful. So it's really important when you establish a registry or when you evaluate a registry that you think about what we call a data value chain. And you have to be sure that the data that's been collected has gone through all these different steps. The number one step is, what's the purpose of this data? Why is this data being collected? You don't just collect data, throw it into the mix and hope something pops out from it. You need to know why you're collecting it from the outset. It needs to be purposeful and it needs to address a knowledge gap. There's no point in collecting data on something we already know. But if there's something we don't understand or where we could value add from better information, then we need to define that knowledge gap. Once you know where you're going and what you want to get out of it, that helps you decide what you need to collect, so which data elements along that care pathway from diagnosis, investigation, management, those key steps, which ones of those are going to inform that data gap. It then moves you on to knowing how you're going to collect that. Is it going to be through data transfer, data linkage, direct data entry? And then finally, once you know what you're collecting, how you're collecting it, you need to be able to double check that you're doing it properly. You need to be able to verify that data. It's really important then to think about, how big a sample of your total population do you need? It's pretty much impossible to get 100% of any given population. So if you take this analogy of people that have been invited to your house for a party and they're asked what their favourite fruit is, and each, because you want to sort of make sure you get the right fruit when you're catering, if let's say equally all your friends like cherries, bananas, apples and pineapples, if you only ring the first four and ask them what they like, you might find that you're over catering on the cherry side and totally under catering on the pineapple side. If you ring 50% of them, you're starting to get a little bit more even spread, but still the pineapples are missing out a little bit. Once you get up to 80%, you're getting to pretty good sort of getting there. You're starting to get a good mix of the different types of fruit that you're going to bring in at your party. But once you get up to 95%, well, it's almost as good as bringing 100% of your friends and understanding so that you understand what you need to buy for your party. Now, in research science, basically, if you are needing to sample a population, you need a bigger sample if it's an uncommon event. And you need a bigger sample when the outcome measure is really important. So, for example, in a bariatric surgery registry, outcome metrics such as descriptive things like demographics or weight change or diabetes treatment are kind of nice to have. They're things we'd like to know. And if you've got an 80% sample, then you're pretty close to what you would get if you had 100% acquisition in your registry. But if you've got really important rare event, if you only sample 80% of your population, you may miss that one death in 1,000. So therefore, you need to try to get as close to 100% of the people who've undergone a bariatric procedure enrolled in your registry so that you don't miss out on that important event. This is what we call reducing selection bias. Then finally, once you have got your data in and you've tried to capture the right amount of the people who are undergoing your intervention, you need to be sure that you're managing your data properly, you're holding it effectively in a safe environment. And then you need to analyse the data very carefully with proper help of statisticians to make sure that it's reliable and robust and biostatistically sound. And finally, you need to tell your message. There's no point in collecting your data if you're not telling people what it shows. So data is the foundation of any clinical quality registry, but it's not the whole story. On top of having standardised data relating to well-defined outcome measures with clear data completeness rules relating to a purpose that you've predefined, you need to ensure that you engage all the stakeholders, which can be your hospitals, clinicians, patients. You need to be sure you've got adequate resources to do all the things you need to do to run a registry. And finally, you need to have very robust governance so that you meet both your national and international privacy laws, as well as different standards around data maintenance and housing. Privacy laws and patient consent participation are very complex, and I'm not going to go into them very far tonight because that's a whole lecture in themselves. Enough to say is that wherever you live in the world, your rules will be different. But the world on the whole is really moving towards individuals knowing where and how their data is being used and having to explicitly consent to have that data used, or have a IRB or ethics committee provide a waiver of consent because they say that it's something that's so important it needs to be done even if the patients don't want their data collected. The one situation where we can sometimes use data without the approval of the patient or an IRB is if we use de-identified data, but the problem is these days with computing power, it's very, very hard to de-identify data because most data can be re-identified with enough time and computing data. So ultimately, we can only justify collecting data now if it's purposeful and it's been collected with a clear view from the outset of what outcomes you want from these data. So it goes back to you shouldn't start this activity unless you know what your purpose is and what the knowledge gap is that you're trying to fill. So why should national bariatric societies consider having a registry? Well, we know that bariatric surgery is an exciting field. We know that it helps our patients, and we know that it's rapidly and constantly changing. I know that the uptake of bariatric surgery over the years has exponentially gone up. So times of rapid uptake of surgical procedures is a time of high risk for patients. And so this is a time that we really need to be monitoring what we're doing and making sure that we're doing what we think we are, which is providing good for our patients, not harm. The registries also can help national societies monitor different trends of what procedures are being done and how they may be changing over time. They can help understand who's receiving bariatric surgery in a given jurisdiction or country, and understanding issues of equity can be really important. And also can enable, if it's mature, us to compare and benchmark procedures, hospitals, practitioners, and even devices. But ultimately, what registries do is help us with our audit cycle so that we can constantly measure what we're doing and seek to do better. So why would Ifso consider having a registry? We're not just one society. We represent over 70 countries across the globe throughout different chapters. And so why would we consider having a registry? So the purpose of the Ifso registry is well defined as being able to provide credible and transparent information on bariatric or metabolic surgery as it occurs across the globe. And the aims of the Ifso Global Registry are to provide descriptive data about the caseload and penetrance of surgery for metabolic disease and obesity in our member countries. So we're not looking at outcome measures so much as what's going on. So it's a descriptive registry, so to speak. We hope in the future that we might be able to provide real-world post-approval surveillance of procedures and devices, so looking at weight loss, complications, and other types of outcomes, but that's something that will take time and will need more engagement with our member societies. So how can Ifso fulfill this purpose of our global registry? So option one is that we could go to every country around the world where bariatric surgery is performed and collect individual level data, put it into a registry and analyse it ourselves and do direct comparisons. That means we would have to host the private information of individuals from every country around the world. The other option we have is to compare outcomes that have already been measured and calculated by national registries and compare them to all our other countries that have registries. So the history of the Ifso Global Registry report is that it started in 2014 in 18 countries. At that time, there was only 2 national registries. And over the years, the numbers of countries participating waxed and waned a little, and the number of operations that we recorded got up to around 800,000, just over 800,000 in 2019. Over time, though, things did change, and the Global Registry Committee was commenced in late 2018 after the publication of the 4th report, as there was a desire to start to bring some more consistency and oversight to these reports that had been started by some very dedicated people in countries that were committed to providing transparent outcomes. Unfortunately, fortunately or unfortunately, I suppose, in 2016, the GDPR, which is the privacy laws that regulate data collection and usage in the Europe, started, and it became enforceable in 2018. And that again is part of the background as to why the Registry Committee was commenced, because it really changed Ifso's relationship with these data. Because remember, these data originally were collected from individuals from all over the globe, and they were de-identified and collated and analysed by Dendrite, a company that is based in the United Kingdom. The data was then compared, but was not statistically analysed. So the key issue became that GDPR changed the regulatory environment from when the registry started. GDPR requires that all data that's being used for secondary purposes has to be meaningfully used and have a clear purpose. And Ifso, at the time the committee started, had not really defined that purpose. That really came at a meeting in Lyon in 2019. Under GDPR, Ifso took responsibility as the data controller, whilst Dendrite was the data processor. That meant that all the legal responsibility for holding the individual level data lay with Ifso and their registry committee. The risk was somewhat mitigated by the use of de-identified data, but Ifso became fully responsible for ensuring that de-identification met the international standards, and they also were responsible for making sure that patients had consented for that de-identified data to be sent internationally. It became apparent to us as an Ifso committee that we really, as a small society, were not in any position to take on this level of responsibility. So the Ifso committee Global Committee met and recommended to the Executive Board that instead of going through option 1 and collecting all individual level data, that we move to option 2, where we shared aggregated data from national registries. By collecting data that had already been analysed and presented to us as means or medians, with their interquartile range or confidence intervals as appropriate, it meant we were no longer responsible for all the processes that underpin the sharing of individual level data. We no longer had to get data sharing agreements. We no longer had to be sure that the patients had consented properly. We didn't have to employ a data protection officer. We're no longer responsible for data destruction. It also meant that we were able to engage with established national registries such as those in the USA, Australia, New Zealand and Israel, where their jurisdictional laws prohibited them sharing that individual level data. And ultimately, by sharing data that was already analysed, we thought that it may prove to be more cost effective. However, there are some limitations to comparing data that's already been analysed, and it was recognised that if we were going to go down this pathway, we needed to be clear that each country gave us an idea of what sample size or what percentage of the people who'd actually undergone a bariatric procedure in their country had actually been collected. So the 7th annual report was the first report that we presented where we compared data that had already been analysed by national registries. The dataset that was decided upon was partly informed by a project we did with Bristol University, helping us to define a minimum dataset for bariatric surgery registries. A data dictionary was completed by Diane Brown at Monash University, and 32 known national or regional registries were invited to participate through Manuela and the Ifso Secretariat, and 25 agreed to participate. The data was then collated through the Monash University Australia New Zealand Bariatric Surgery Registry team on a REDCap database, and the data was analysed using a data visualisations expert based in the Netherlands. And then the data was presented through a report that was authorised through the registry committee. This is a summary of what we were able to collect from around the world in this first collated report. And you see that we collected data from very many different countries, and we were able then to give a good overview of the state of play of what different types of procedures were being done, and also some key outcomes such as safety, where we showed that there was less than 1% deaths following bariatric metabolic surgery around the world, and also in terms of diabetes, that diabetes was a common indicator, for example, for metabolic surgery. So monitoring new processes requires careful data collection of a lean data set of predetermined data elements, enabling us to collect meaningful information on outcomes. An effective registry requires planning and resources, and before undertaking a registry, it's really important that people think about, do they need a registry? Will a sample do? Could data be collected in other ways, such as through a trial? You need to have recruitment and collection strategies to minimise bias. You need patient consent. You need data security and validation. You also need reporting that includes stratification, and you need to observe privacy laws. It's critical that you understand what you're trying to achieve at the outset. For the Ifso Global Registry, this is to provide descriptive information on what's going on around the globe in terms of bariatric surgery. So who's having the procedure, why they're having the procedure, and if there's any particular equity issues around access to bariatric surgery. Because of the changing regulatory environment, Ifso has switched from collecting individual level data to now collating data that's already been analysed by national registries and comparing those in our reports. Ultimately, Ifso would like every national society to have a registry, and one of our key goals this year is to take the learnings from when we used to collect individual data and use that to help new societies establish bariatric surgery registries moving forward. And that will be the focus of a postgraduate course before the Ifso meeting in Naples, which I hope many of you will be able to attend. So I'd just like to acknowledge all my colleagues that have helped me over the years as we've established registry, and I look forward to the rest of the webinar.
Hello, my name's Jennifer Holland and I'm the Executive Officer at the Australia and Aotearoa New Zealand Bariatric Surgery Registry. Our registry is based at Monash University in Melbourne, Australia, and we worked with the Ifso registry team last year to collate the aggregate data for the 7th Global Registry Report. So Wendy's provided you with a great overview of registries and the Ifso Global Registry's work to date, and I'm going to briefly go over the work we did to collate the aggregate data submissions and get that data off to the data analyst for the global report. So as a general overview, we started with developing a data dictionary. We built an online database using REDCap. We facilitated data submissions from member countries, and there were 2 ways countries could submit data. And we did some data quality checking, and then finally we had a data set to send off to the data analyst for the global report. So last year we had data submitted by 23 national and 2 large regional registries, and that was over 300,000 procedures internationally. The way the data was submitted was that 57% of the countries submitted by directly entering into our online database, and then another 10 submitted by sending through a spreadsheet with their data, which our team then uploaded into the database. So first, a data dictionary was developed, and this was developed by Diane Brown with input from the Ifso Registry Committee. The data that was to be collected could be split into 3 categories. So the breakdown of procedures, some patient characteristics, and then outcome data. And I'll go into these a little bit more detail, and they're covered in detail in our data dictionary. So our data dictionary is an Excel spreadsheet. An example of a definition is this one for sleeve gastrectomy. So you can see we have the definition, the purpose of the data item, and we also have a reference to how it's recorded in Dendrite for anyone that was using that registry system. The next step was to set up our database. We used REDCap. Monash University has an instance of REDCap, which is a web-based application that can be accessed across the world. We used it to receive and collate the data in a standardized manner. A very brief overview of REDCap. You can access it online. We were able to set up individual user accounts, so one for each country that was submitting data. When accessing the project, that country could only see their own data. This year it also has 2-factor authentication by email, so it has an extra level of security. We developed a step-by-step user manual, and for those who couldn't access REDCap or chose not to, we had an alternative method of submission, which was to send us data using an Excel spreadsheet, and then we uploaded it into the REDCap system. This is what REDCap looks like. You can see at the top there that I'm in the data access group for Australia, and then you can see at the bottom that there's a space for the 2021 data and then the 2022 data, which will be collected this year. So the online data entry forms are predominantly set up as data tables like the one on the screen. You can see at the top here, we're in the Australia data entry form, and it's for the 2021 operation data. We need to cross-check with our data dictionary definitions when we're providing the data. Here we've got the definitions of primary and revisional. It's important to note that revisional procedures exclude remedial and salvage procedures, and the definition gives some examples of what's excluded. Across the top, you can see that it's split into male, female, and all. Again, checking our sex definition, we can see that there might be instances where we don't have a person's sex recorded, or we might have it recorded using another term. So when you're putting in your total for all procedures, you should include those that might use a term other than male or female, or where sex is unknown or missing. Here's another example. This is procedure type On this one, you'll see there's a space to put unspecified. So if you don't know whether they're primary or revision procedures in your registry, you can note the number down here. You can also see that we have an other and unknown category. So the main categories collected for procedure type are sleeve gastrectomy, OAGB, RYGB, and gastric band. Looking at operative approach, the definitions are very important here again, and we've even put them on the data entry form. There is a hierarchy for how we want to capture the operative approach data. So starting at the top is laparotomy or open procedures, and this should include any procedure that has an open component, regardless of whether it started out as laparoscopic or endoscopic. If it converted to an open procedure, that's the operative approach that should be recorded. Next in the hierarchy is robotic. So that's any procedure that has used the assistance of a robot, excluding open procedures. Laparoscopic is any laparoscopic procedure, excluding those with robotic or open components. And then we've got endoscopic and unspecified. Now we're in the patient characteristics section. This includes collecting age at surgery, BMI at surgery, and some obesity-related diseases. Here we've got age at surgery. You'll see that for this, we're asking for some descriptive stats. So we're asking for median, we're asking for interquartile range, which includes lower quartile and upper quartile, and the definitions of these statistics are included in the data dictionary. And then in the final column, we're asking for the number of procedures where the age at surgery is known. We want to know this so we can use it to determine how much data is missing. So if you don't have an age at procedure collected, then they don't go into this table. You are only including the number where you know the age at procedure. These are the obesity-related diseases that are collected for primary procedures only. What you'll note with the data collection for these is we've got the table format again, but we do have a spot at the bottom for you to note the definition that you use for that particular comorbidity, because we know that they might differ between registries. So for example, in the Australian registry, we don't collect whether it's type 2 or type 1 diabetes. So our data is just anyone that has diabetes noted. Finally, we've got the outcome data. What you will notice with this is for the perioperative outcomes, you can select at the top whether you are looking at 90 days from procedure or 30 days from procedure, because we know registries might be collecting it for different time periods. You can also see here that we have an extra little note to guide you in your recording, which is a reminder that you should exclude procedures where a readmission status is unknown or missing. So this one's for unplanned readmission. These are the other outcome data that we collect, so length of stay, unplanned readmission rate, unplanned return to theatre, unplanned ICU admission, and also deaths within that perioperative period. So we developed a number of guides and references to help with your data submission. The first, and the one that I've mentioned most, is our registry data definitions or data dictionary. It's in an Excel spreadsheet. It has some extra information about how to submit your data and definitions of statistics. For those submitting through REDCap, we have a step-by-step user guide. We have an example data entry, so that helps you understand what the data is we're asking for. And our database manager, Angus Campbell, has even created an instructional video that you can watch if you're still unsure. For those that are emailing their data, we have a Excel template for you to use, and you should look at that in conjunction with the data dictionary to work out what you need to provide us. Talking about data quality now, we do recommend each country check their data analysis. We want you to check for data entry errors. We will check your submissions, and if there's any issues, we'll send a query. We'll also send you a PDF of your data back so you can do another check for any data entry errors. And then once we've passed on the data to the data analyst, they may come back to you with other queries. But basically the message is, if there's anything you're unsure of, please do ask us and we are here to help. So in summary, for the next or the 8th Ifso Global Report, the timeline for submissions is still being finalised. You'll hear about that soon. When you are submitting, you'll be given all of the resources that you need. Please wait until we've sent this year's guidelines and templates before preparing your data. There might be slight differences to last year. And if you don't already have a REDCap user account, we will be setting one up for you and we'll be in contact about that. Wendy's already thanked sort of the broader team here based at Monash, so I won't go into the individuals, but thank you to everyone that's helped make this possible, and we do really look forward to receiving your data submissions this year.
We can't hear you, Wendy, and I'm hoping people can hear me. We've had a few technical issues in the background here, but next up we'll go to Ronald's presentation, and then hopefully we'll have those sorted for a Q&A session afterwards. So we'll pass over to Ronald now.
Good afternoon. Also warm welcome from me to this Ifso Registry webinar that is organized by the Ifso Registry Committee. My name is Ronald Liem. I am the Vice Chair of the Ifso Registry Committee, but also I'm a bariatric surgeon in the Netherlands. I'm the Director of the Dutch Obesity Clinic in The Hague and Gouda, a high volume center. And also I am the chair of the Ifso European Chapter Multinational Advisory Group. I'm a member of the Task Force ERAPS. I am a Clinical Audit Board member of DATO, the National Registry in the Netherlands, and I'm the past president of the Dutch Society for Metabolic Surgery. These are my disclosures. Maybe a little bit abundant, but I think very important to stress again that the purpose of a registry, of course, is to collect data in order to establish safety and efficacy and outcome of our treatments in order to improve care delivery, preferably also establish some cost savings. It might be mandatory for reimbursement of the treatments, and then after data collection, benchmarking is possible, and also research within a registry. To establish a registry, quite a lot of time and effort is needed. We started the Dutch registry in 2015. But as you can see, the timeline that was involved in creating this national registry is quite fast, already starting with ideas in the early 2000s and then ending up with a mature registry at current times as we have it now. So there are a lot of challenges in regards to establishing a national registry. Of course, you have to think about the data dictionaries, but also how to establish completeness of data. You have to think of data integrity and verification. Of course, the registry has to be maintained. Clinical audit board is necessary to further improve the registry. Somebody has to govern the registry, and of course funding is also a major issue, and then especially in Europe, but I think all over the world, privacy of patients should be taken care of. GDPR in the European Union is quite strict on that. So for this webinar, I want to talk about data dictionaries in general, and all the other challenges facing a national registry, and creating a national registry will be addressed in the upcoming postgraduate course during the World Congress of Ifso this summer in Naples. That course will be organized on Tuesday, August 29th, the day before the start of the World Congress, and everybody involved in a national registry or thinking about starting a national registry is warmly invited to this course, where we will elaborate on the development and improvement of national registries. So if you focus on registry dictionaries, then of course you think of baseline characteristics of our patients, but also about the outcome, the clinical outcome of our treatments. We want to register morbidity and mortality of our treatments, and then lastly, but very important also, quality of life and patient-reported outcome measures. So, easy job, you would think, right? Unfortunately, the truth is a little bit different. We did a comparison between all the existing international national registries available in the 2020-2021 time frame, and we recognized 80 national registries or regional registries that were organized as a national registry, and we looked at all the data dictionaries that were available in these national registries. So we could identify all variables for 11 national bariatric registries, and over 2,500 variables were identified. Of these, we had to exclude a number of variables, and all in all, 2,550 variables were identified and analyzed. We did a grouping of all these variables across 6 domains, and those domains were patient domain containing 16 variables, prior bariatric history domain, screening domain, operation domain, complication domain, and the follow-up domain. Then all these variables were mapped for perfect agreement by domain on the following points: if it was registered or it was not registered, and there were some matching definitions also. And if you look at the results of this comparison, then a little bit to our surprise, the variables with the perfect agreement in patient domain were only 3, and that is not even 20% of all the variables in that domain. Of course, patient ID number, date of birth, and sex were in agreement over all national registries. But then, if you look at prior bariatric history, there are actually no variables that were perfectly aligned across all the national registries. And same for the screening domain, only 5 variables had perfect agreement. Those were healthcare institution, hospital ID, the height, the weight of the patient, the diagnosis of diabetes mellitus. In the operation domain, only 6 variables were in agreement, and those were again healthcare institution and hospital ID, the preoperative weight, the date of the operation, the type of procedure, and details of other operations prior to this bariatric procedure. Then in the complication domain, only 5 variables were agreed upon throughout all national registries, and again those were healthcare institution and hospital ID, and then more important, bleeding, leak, and surgical complications. And if you look at the follow-up domain, also only 6 variables were in agreement. Again, healthcare institution, hospital ID, and then more important, date of follow-up, weight, the diagnosis diabetes mellitus, and the medical treatment of diabetes mellitus. So if you look at the various levels of agreement over the domains, you can see that perfect agreement is only reached in a limited amount of variables. Then of course there's a substantial agreement, a little bit adding to the total, and a moderate agreement, but nothing adds up to 100%. So to conclude this comparison, we can say that there is a limited uniform agreement in variables across national bariatric registries, and further alignment and uniformity in collected variables are required to enable future international collaboration and comparison. And that is quite remarkable, because I think as surgeons and healthcare professionals, we think alike, and you would think that we would measure the same outcome measures in order to analyze our treatments. But this comparison clearly states that that is not the case. So we started a project within the Ifso Registry Committee with help of Bristol University to define a core outcome set, the bare minimal amount of variables that should be registered in all registries to be able to compare. So when we started this project, we recognized that robust long-term data comparing the effectiveness of different bariatric operations is actually lacking. And data from prospectively collected clinical registries can make an important contribution to this evidence base. But we need to agree on standard set of items to be collected in bariatric surgery registries to allow data to be compared across countries. And a first step towards unifying bariatric surgery registries internationally, we came up with this core outcome set project. We developed a core registry set, which is a core set of items to be included in bariatric surgery registries globally. And the focus is on non-patient reported outcomes, because there is a parallel project going on that is actually looking into the core quality of life measures for obesity treatment. We did this in a 2-round Delphi survey with international multidisciplinary health professionals, and we concluded this process with 12 items where all healthcare professionals agreed upon that it should be as a minimal data set in any national registry. And of course, most of these items do sound logical, but I want to mention them to you anyway, because this should be included in a national registry from the beginning and as the bare minimum. It's history of any bariatric procedure, so prior bariatric history should be reported. Of course, age, height, sex, and weight of the patient. Type 2 diabetes diagnosis, type 2 diabetes medication, reflux disease, of course the name of the surgical procedure, clinical malnutrition before or after bariatric surgery, whether a reinfection has occurred and the classification of its severity, and in-hospital mortality. So I want to stress that, of course, this is not the complete set you should have in a national registry. The complete set, the complete data dictionary shall be much larger, but these items should be in it anyway. The PROM that were selected were the body cue, addressing physical functioning, physical symptoms, physiological functioning, social functioning, eating behavior, and body image. The IWQOL light is used for the self-image questionnaire. The COLOS is used for excess skin, and unfortunately there is no PROM available to address stigma. I think one of the more important domains that is identified in the past few years. So in summary, there is a need for reliable long-term data on bariatric surgery. We need to be able to compare these data, not only about clinical outcome, but also patient-reported outcome. And we need more national registry globally on top of the 18 registries already identified. So please submit your national registry data in a timely fashion to REDCap in order that we can analyze this data and produce the 8th Ifso Global Registry report that will be presented during the Naples Congress of Ifso. please contact us when you experience difficulties delivering these data, or if you start to plan a national registry in your own country and you're not fully aware on how to proceed. We might be of help. Of course, there are quite a few mature registries already available globally, and we are happy to advise national societies that are trying to develop a national registry. So thank you for your attention, and I want to remind you again of the upcoming postgraduate course during the World Congress of Ifso in Naples. That will be all about registries, the purpose of registries, and how to establish a national registry. So I hope we will welcome you to Naples and participate in this postgraduate course. And of course, everybody is now open for questions. Thanks again.
I don't know if my microphone works. Can you hear me?
Yeah, we can hear you.
We can hear you. We can hear you.
Finally.
I changed microphones. So I apologise that you didn't hear my introduction of Jennifer Holland. Jennifer is the Executive Officer of the Bariatric Surgery Registry for Australia and Aotearoa, New Zealand, and she's a registry expert, so we're very grateful to have her expertise, and I think her talk was fantastic. So I'm going to hand over now to Ronald, who's going to lead the question and answer time.
Thank you, Wendy. Well, we were facing a little bit of technical, and I hear an echo. I don't know if there are questions at the moment.
Ronald, I'll ask you a question. What can people expect from the postgraduate course in August?
Yeah, that is a good question indeed. In our prior postgraduate course, we more or less focused on what already is going on, and actually we want to give tools now, concrete tools to societies who are actually planning to start up with their own national registry. So of course, we have a lot of lessons learned, and there are quite a couple of mature registries available that can be of help. So if there are people out there that are planning to start a national registry, I would gladly invite you to the postgraduate course so we can get people started.
There's also a question in the chat from Andre Curie around whether or not we have a rough time on timelines and when the data dictionary might be made available. We have the data dictionary for the global report available, I'd say now. And we can provide you with that. We are working on a more formal data dictionary for registries and for emerging registries, and we've gone through a consensus process, as Ronald explained, to identify the data items that we're going to use, and we've also gone through a consensus process to how we define those data items. And that particular data dictionary, I think we should be able to release at the Naples meeting. But for the upcoming report, we already have a data dictionary which we can share. We are hoping to receive all the data, I'd say by late April, for the upcoming 8th report. We're hoping to have a meeting in May of all the registries who contribute to the 8th report, so that we can look at the data and make sure we've got it accurate before we finalise it and write the narrative. So just a chance to get feedback, and that'll be another webinar. We don't have an exact date in April because we've just had to change our data analyst, so sorry about that.
So Jacques Hempens from Belgium, he's asking, how do you deliver the data to REDCap? Is it on an institutional level or is it centralized? Great question, Jacques. It depends, of course, how the national registry is organized. If you do not have a national registry, of course, you cannot enter data anymore to the global IFSO report, because we only take into account data, centralized data from the national registries. And to avoid problems with GDPR, it has to be collated data. So it is provided centralized by the national registries into REDCap, if that's an answer to your question, Jacques.
So we're basically getting means and medians and interquartile ranges, things like that from the national
registry. So it's pretty much simple statistics. Yes.
But if REDCap's a problem for you and you can't enter it into REDCap, we also will receive it on any sort of form that you like, and the team will be able to enter it into the registry for us.
So another question is how we verify the quality of the data. Yeah, that is the Achilles heel of all registries. Data verification, of course, is very important. I think national registries should take care of data verification themselves. Of course, it's impossible for Ifso to double check on the accuracy of data. So we are actually leaning on the data integrity that is provided by the national societies. So we're at 1 o'clock, but there is this one last question out of Korea. We submitted only patient summary data to Ifso registry. When is the due date of registry input for the 8th Ifso data registry? End of April, that is. And should we solve GDPR problem in each country? The way we're actually asking data to provide to Ifso Global Registry is bypassing GDPR, because it's not you cannot track it back to patient level. So that is the reason why we only ask collated data out of the national registries. So we are not hampered by GDPR in Ifso Global Registry. And then there is another question for the next report. What dates will you collect data for? Preferably all of 2022, but USA is always 1 year behind because they have such a big registry, so they cannot come up with the complete data set in time to provide it to the global registry. So preferably the past year, and USA is the only exception to that rule at the moment. Then the next question is from Austria, Felix Langer. Thank you, Felix. Will the data format be the same for 2022 as it was for 21? Yes, it will be, and much more to be discussed in Naples when we gather again. So we try to use the postgraduate course also to meet up with most people participating in the global registry to see if we can actually work on the content of our global registry more than it is at the moment. So we started off with this really basic dictionary, and if everybody thinks that the dictionary should be enlarged a little bit more for the global report, then of course we're happy to discuss that and to change accordingly for the next issues.
There's a question about the cost from Bruno Dillemans. There's no cost. REDCap, if you're a charity or a not-for-profit organisation, is a free program, and Ifso is covering the cost of data collation and the data presentation for the report. So there should be no cost to the national societies.
Then there is another question from Jacques Himpens. He's asking if we can imagine that Dendrite feeds its existing data to the new collector. I guess not. I think Dendrite is providing national registries to a couple of countries. And of course, those countries can extract their own data from Dendrite and provide it to Ifso Global Registry. I don't think that Dendrite will be willing to automate data transfer from them to us. So that has to be with the national society itself as the data owner to provide it to the global report.
And hopefully that's not too big an issue, because these are fields that hopefully they're presenting in their reports anyway. And we did receive data from Q8, and I think Q8 curates the data. Their data is curated by Dendrite.
Same goes for the UK.
Yeah, we just didn't get the UK last time, but that was around, I think, the timing.
Next question is from Brazil. Can we already use the body queue? Yes, of course you can use the body queue, because it is freely available through the people in Boston and McMaster's. If you would consider using the adapted body queue for obesity surgery that is in use now in the Netherlands, it can be translated, of course. Most of the questionnaires are already available in English. There's only one subskill that has been added to it. It's about eating, but I think it is already available in English. So if you want to use the body queue on a national level, please reach out. I'm happy to establish the contact between the Boston McMaster's group that are actually owning the body queue, but it's free of charge to use it if you are a registry, a national registry. I must say I'm very happy about the amount of attendees this afternoon. It's not the most sexy topic if you are discussing bariatric surgery, but I think a very important topic to be discussed. So it's good that we have a nice engagement today. Thank you for that. Thank you for your time joining us. Are there any more questions, Manuela? Nope, she says. So we run out of questions. We almost ran out of time also. It's past 1. I think that the Australians are really looking forward to have a good sleep tonight, and the rest of us go back to work. And well, happy that you all joined us, and of course we hope to see a lot of you back in Naples as participants for the postgraduate course. But in the meantime, we are really readily available by email to help or to advise in any way. And if you come across problems delivering data to RedCap, Jennifer also is happy to assist. So thanks again. Thank you, Wendy. Thank you, Jennifer. Thank you, Manuela, for hosting. And we'll see you in Naples.
And don't forget the webinar will be available later today.
Yeah, absolutely.
All right. Thank you, everyone.
Bye-bye, everybody.
Bye.